navigation in total knee arthroplasty. The first question is that comes to our mind when we think if this is worthwhile, what would be navigation's contribution to the knee arthroplasty? And more important, if that has impact on clinical results. So we started doing the navigation in the early years of last decade as it evolved in Europe. This was the first case we did. And in this time, the main concern was about alignment. So there was a lot of emphasis on the fact that you could get within a navigator into the mechanical axis in opposing to the anatomical axis. That is what we can see in surgery with the regular conventional guides. So the computer sees the mechanical axis directly, and this would assist us in getting a properly aligned knee, where hip, knee, and ankle would be in a straight line with a 0-degree mechanical axis. So, and this was the main concern of which navigation turned around in this time. Also, not only in the coronal but also in the sagittal plane. So we had 5 axes: the mechanical axis and the coronal and sagittal plane for tibia and for femur. These were the same main parameters for navigation. The results of our first series in this time, in 2002, we had 72 knees with a preoperative medial axial deviation of about 9 to 10 degrees and a post-operative axis around 0 degrees with practically 98% within the so-called security margin of 3 degrees. And at this time, many publications around the world showed the same. Yes, navigation delivers precision to bone cuts and better limb alignment. How important is this, and what is the clinical significance and impact is still to be proven and discussed. But this has been questioned by some authors. Is alignment so important? We have important work from the Mayo Group that shows that they have a 15-year follow-up, and they have a group of outliers from this margin of 3 degrees of correction of their alignment with results similar to those that are within the safety margin. So undoubtedly, there are many other factors that affect the results of a total knee replacement. I'm sure, in spite of this, that nobody will say that alignment is not important, but it surely isn't the only parameter, nor even the most important. So navigation also evolved to trying to control other factors during surgery. So basically the navigation system gives you enhanced precision. So this is why you can get a better alignment and correcting the deformities. But you can also use it to increase your ligament balancing and have more control around stability, trying to enhance the main objectives that would be to increase longevity and give better function to the patients. So the most modern systems the software gives you the possibility of having an objective ligament balancing to measure and equalize more objectively flexion extension gap, gives you control on femoral rotation and also on tibial rotation. So a navigation system gives the surgeon a lot of feedback during surgery. And on the contrary of what some say that it's for an unexperienced surgeon, I think this feedback gives much more resources and information for those who know how to deal with them. So the more experienced you are, I think the more you get from a navigation system. And something that some systems have is the possibility of you having an intraoperative simulation of some steps. So here's the orthopilot screen. After you have the tibial cut, you can plan the femoral cut and change size of the femur, size of the polyethylene, rotation, and see the effect it will have on the gap balancing after you have already measured the tension and flexion and extension, and this is achieved by the system, and so it can do a prediction of the results of what you're planning to do, and you make your decision based on these projections, plan your femoral cut, and go on from there. So you have some intraoperative planning and testing. Well, so what is navigation contribution? Is alignment better? Surely. Alignment, I think, is definitely better, improved in literature. Is ligament balance better? We don't have anything yet to prove this. Does it have clinical relevance? We can't prove that yet also. We now are achieving maybe 10 to 15 years of navigation in total knee arthroplasty. Obviously, that the most long cases are the first ones where we had less parameters being controlled. But the studies are starting to come out. We are starting to prepare our 15-year results with these cases that were published in 2002. And I really don't know if we'll have clinical relevance, but I'm sure it is a tool that assists the surgeon in a very significant manner in surgery. So should it be done routinely? I don't know. If you have it, why not? But it certainly is more significant in harder cases, like when you have complex deformities, very obese patients, difficulty to assess the femoral canal, and so on. So here we have some cases on the top, Page's disease with a severe deformity of the tibia, where navigation helped us to get a good alignment, an obese patient with a bilateral surgery in 2 separate occasions, also with a good alignment and a good clinical result. So our situations where we would have more difficulty with conventional surgery. Here a middle-aged woman with a valgus deformity and little flexion resulting from multiple surgeries from a congenital condition. So a situation where we would have great alteration of the normal anatomical references and more difficulty to do with a conventional case. So this was a navigated surgery. You see a severe valgus deformity, and we obtained a very good correction with the aid of the navigation system, good alignment, and a good clinical result. Here you see the patient on the immediate postoperative. This is the other leg, and this is the operated leg, so she has a fairly good range of movement. And this would be her 1 year after the surgery. So I don't say you can achieve it with a regular system, but certainly it's a lot more easier with a navigation system. And this is the final result and alignment of this case. So many other situations. You see hardware in the femur. You couldn't use an intramedullary device, so navigation can go very easily around this. A complex deformity after a femur fracture with a tibial osteotomy and still a varus knee. Very much easier to do with a navigation system. A young man with a comminuted supracondylar femoral fracture treated with this toothpick fixation and with this clinical result, with this hydrological result. Also a hard case to do with a regular system, and we could go around this using the navigating system with a good radiological and clinical result. Deformity also from a distal femoral fracture. We couldn't use an intramedullary guide. So again, with navigation, we can easily go around these difficulties. So I think that more important is what do intend to achieve technically in a total knee arthroplasty. Navigation doesn't give answers. Navigation lets you go where you want to go. So if alignment isn't important, don't use it for alignment. Use it for whatever you want. If you think that a 0-degree axis isn't the correct one, you want something different, it will just take you where you want. So really the more important piece is the one that's behind the navigator. So what do you want? What is the ideal alignment? What is the correct femoral rotation? What is the tibial rotation? You want to preserve, sacrifice PCL? Can anyone here say what is the correct tension of ligaments and flexion or extension? With the navigation system, you can measure this. I can say I can get 10 millimeters with a determined tension. What is the correct number? Nobody knows that. I have my numbers when I operate, and that depends on the force I put on the knee. Another surgeon certainly will have different numbers, but the fact that we can measure them means that we can learn with time, and we can get experience, and we can get research to show, maybe show what are the better ways, and also individualize this for each one, because we can see intraoperatively the results of some of the steps we are planning during surgery. So navigation is a precision instrument, and is an instrument that gives us a real-time control of what we are doing, the possibility of verification if we really got the cuts and the tensions the way we wanted it. We don't have to see this after surgery. Have the possibility of having an intraoperative simulation and planning tool, and is an excellent tool for registration of everything we do in surgery. So documentation will be very thorough and will be a great tool for research and for learning from what we've been doing. So this is what I wanted to say. Thank you all very much.